All been on med surg before. We have diabetics who have their foot, their toe cut off, and then another toe cut off, another toe cut off, and so on and so on. And, what they usually do is, a lot of those, especially these older guys that are on insulin, they'll, age pass, so they'll take a couple more years of insulin, and, they start to manage their own, and obviously, it doesn't work because clearly they end up losing digits and things like that. So compliance is probably the biggest issue with diabetes. Gestational diabetes is no different because you're dealing with young, healthy females for the most part who think they're invincible. All of us under 30, whoever that of you that is, I say us, and it's not me clearly, but all of you under 30 think you're invincible. And you'll find out, eventually that you're not, but you think you are. And, it's not going to hurt me, I'll be fine. And until their baby, their estimated fetal weight is 10.5 pounds, and they realize, okay, I didn't follow the rules, and now I'm kind of getting into a little bit of trouble here. So, all right, so I told you we would go back to this slide and talk about that after we talked about the diagnostics. So we talked about diagnostics for gestational diabetes, and our two major field concerns. We're not worried about congenital anomalies with gestational diabetes, right? Because we're not diagnosed until they're 16 weeks at least. So aren't all the organs formed by that time? All the fetal organs are formed. So we're not worried about congenital anomalies with gestational diabetes. Make sure you get that through your head. The biggest thing I see with students and diabetes is getting confused between type 1 and type 2 and gestation, being able to know the differences. So if you do anything when you get home, make yourself a list. This side gestational, this side type 1 and type 2. Write out the differences. It's a good way to study. Write them all down so that, yourself, so that you can understand what the differences are. And if we had a little bit more time, we'd do it on the board. Maybe Wednesday we'll review and we'll just right. This is some on this side, some on the other. But what are the differences between gestational and type 1 and type 2? We're not worried about congenital anomalies because they're not diabetic at that point in the pregnancy. So we are worried about fetal macrosomia. Baby get too big because mom's not managing her diabetes. That's number one. Number two, fetal hypoglycemia after birth. Well, we talked about that already. Why do the babies have hypoglycemia after birth? Because their sugar supply gets cut off when the cord gets cut, right? So they've not been managing their own blood sugar because their blood sugar's been so high, basically, that as soon as we cut the cord, their sugar drops. They're not able to control their blood sugar very well because they've been running so high. So again, the screening for gestational diabetes is at 16 and 28 weeks. 16 and 28 weeks. If at 28 weeks the patient screens normal, we go on about the pregnancy and we say they're normal. We don't usually see patients become diabetic after 28 weeks. Usually if they're okay at 28 weeks, they're okay. Okay, so antepartum means pregnancy, basically, during pregnancy care. So antepartum care during pregnancy care for our gestational diabetics, diet and exercise, 2,000 to 2,500 calorie ADA diet, again, depending on the patient and their size and what they're used to eating. Exercise increases insulin sensitivity. What does that mean? Exercise increases insulin sensitivity. So patients who exercise, blood sugar will be better because insulin is more effective, is more sensitive when they exercise. So we do want to encourage exercise. We just have to watch their blood sugar. They're going to have to monitor their glucose levels fasting, 2 hours past meals. Remember I said these patients are going to have to be managing their blood sugar, checking it 4 to 6 times a day. They're going to have a glucose machine. Not going to like it. They're going to have to learn to stick their finger. And they need you, we usually tell them to get a notebook, put the date in, or a calendar, but if they have a calendar, it has to be big enough to have 4 or 6 lines on it. They need to write, the date, the time of day, what their blood sugar was, keep it on a paper every day, and then they need to bring it to the doctor every time they go to the doctor. So the doctor can look. How else can we know if their sugars are okay unless we see the chart, see what they've written down? We don't want them just to throw out there, I usually run somewhere in between this and this. And usually when they say that, they round it off to something that sounds a little more favorable. So we want to see what they actually are. Write the number down, what we tell them, and bring it in with you when you come in. 25% approximately, maybe a few more, but remember I said 75% of your gestational diabetics are diet controlled. and 25% are medication controlled. So around 25% will need medication. And our oral agents is what we start with. Glyburide and metformin are the ones we use first for a pregnant woman. Draw a circle around it, underline it, whatever you do to help you remember something. Those are the ones that are safe for pregnancy. Glyburide, metformin, or regular insulin with a sliding scale. What do you think is good about regular insulin with a sliding scale? What does that give us that's helpful to us? Sure, yeah. Hour to hour control almost, or blood sugar to blood sugar control. So it gives us a very tight control. If your fasting's 90, you're good. If it's slide, you all know what a sliding scale is, right? If it's 90, you give no units. If it's 110, you give this. If it's 150, you give this. So if they have a sliding scale, we can really keep them in tight control. So to be honest, I find they do best with a sliding scale in terms of their blood sugars. They don't like that. They would rather be able to take a pill, but control is better with regular. We started using glyburide and metformin a good bit, and it's okay, but I find the sliding scale most effective. We don't give them, why don't we give them NPH or long-acting insulin? Because diabetes is a pregnancy-induced diabetes or gestational diabetes is a short-term problem. So their needs change so quickly. To put them on a long-acting drug when that might have worked last week, and now this week it doesn't work anymore because their insulin needs have changed. So their insulin needs change so quickly, and it's such a short-term problem. So we get the best management off of regular insulin, which is the shortest acting, which is short acting. We'll also have to do fetal surveillance in the third trimester, and that means making sure our baby's doing okay. Because again, I mean, if you're gestational diabetic, if it's severe enough, they can have TKA as well. They can have blood sugar in the 400 or 500 range. It's not as typical as with the type 1 diabetic, but it could happen. So we need to know the babies are okay. We also need to look for polyhydramnios, just like, those are similarities to type 1 and type 2. We look for polyhydramnios, assess for macrosomia, do fetal surveillance, make sure our baby's okay so we don't have the intrauterine fetal death related to metabolic acidosis. And that's how we manage them. Diet, monitor the glucose levels, give them medications if indicated, assess the baby in the third trimester for fetal well-being, assess for a big baby, and assess for too much amniotic fluid or polyhydramnios. Questions about that? Everybody with me? Any questions? Make sure if you have a question, this is the time to ask. Yes, I sure can. Okay. So what are we going to do for our gestational diabetic patients? Diet. We're going to put on a specific diet. We'll start with that. 2,000 to 2,500 calorie ADA based on their size, based on their typical diet. Monitor their blood sugar. We're going to teach them how to do their own blood sugars at home, probably 4 to 6 times a day. So we're going to have them write them down and keep a record for us. Medication, if they need it, if their blood sugars are not under control, we will give them medication. Medications are usually going to be oral agents, glyburide and metformin, or regular insulin with a sliding scale. One of the two. Or one of the three, actually. Count it, 2 men. And then fetal surveillance in the third trimester, looking to make sure the baby's okay. Making sure that, hopefully the mom doesn't have diabetic ketoacidosis because that's what causes intrauterine fetal death. So fetal surveillance in the third trimester. And then assess for big baby, macrosomia, and assess for polyhydramnios, too much amniotic fluid. And we would do both of these by ultrasound. Diabetic ketoacidosis, or which is a form, of metabolic acidosis. Now, if I said to you, diabetic ketoacidosis, they have that you all understand that is metabolic acidosis, a type of, right? Okay. Okay, now, here's what's funny about gestational diabetes. When you have the baby, you are cured. You're cured right then and there. As a matter of fact, after you have the baby, they don't even do a fasting blood sugar the next morning. They just say regular diet, cured, check off, you're cured. So even patients who required insulin, even patients who had trouble with their blood sugar, even patients who were on medication, at birth, they are cured. They do not have gestational diabetes any longer. Unlike preeclampsia and other things that tend to hang around for a while after birth, this does not. So we don't do anything after birth. If I asked you a question and said, your gestational diabetic patient delivered yesterday, what postpartum orders would you expect to see today? You should look for regular diet, all normal things. No fasting blood sugar, no insulin, no special diet, no nothing. They're normal. Now, what we do tell them is that you have gestational diabetes. This increases your risk of having type 2 diabetes later in your life. So when you're 50 or 60, or you may have type 2 diabetes. It is possible. It's not a for sure thing, but you are at higher risk if you had gestational diabetes. And the younger you have, like if you had it, if you're pregnant at 22 and you had significant gestational diabetes, there's a real good chance when you're 50, you're going to have type 2 diabetes. Now, the older you are when you first have it, the less severe it is, the less likely that is to follow you as type 2 diabetes. So it's not that it leads to it necessarily, it's just there's an association with it. Does that make sense? So it is a self-curing disorder. After birth is the cure, but we do need to tell women to be aware when you're older, you might need to be tested for type 2 diabetes if there's an association with it. Okay, so we're going to move on to heart problems. So away from diabetes. Anybody have any questions about diabetes? Whether it's type 1, type 2, or gestational? Okay. And I would, kind of like I said, I highly recommend that you go home and you start writing down for yourself for study. Characteristics of type 1 and type 2 over here. Characteristics of gestational diabetes over here. And there are some differences. There are similarities, and you might even want to have a third column, differences, and then your third column is similarities. Where is it similar and where is it different? Because the hardest thing I find students have to be able to do is to differentiate between type 1 and type 2 and gestational. What are the differences? Yes, there are similarities, but there are differences. Okay, so because there are major physiological changes in the heart and in the bloodstream and the vascular system in pregnancy, women who have underlying heart problems are very much affected by pregnancy. So things that normally happen in pregnancy, you have changes in cardiac output during labor and birth, that we're going to talk about just a minute, that are normal. You have increased vascular volume. I talked about that a lot on the recording that I made. I talked about it in the Zoom meeting as well. You have a big increase in vascular fluid volume normally during pregnancy. Remember I said 1,000 to 1,500 ml extra fluid is added to your blood system, to your blood when you're pregnant. That's normal. So what happens now if you have congestive heart failure and you're pregnant and we just added 1.5 liters of extra fluid to you? That's really going to put you at risk of, more significant disease if you have an illness already. So all those things, in addition, you have intravascular volume changes that occur right at childbirth. We're going to talk about that in just a minute. All those things predispose you to really being at risk if you've got heart problems already. So that extra 1,000 to 1,500 mLs of fluid that I just talked about, that you gain during pregnancy, by term it's up to 1,000 to 1,500. It goes up steadily during pregnancy. So what goes in must come out, right? So you have the baby, you don't need that anymore. So you got to get rid of it. How are we going to get rid of it? Well, when you have fluid inside your body, how does it get out usually? How do you get rid of extra fluid in your body? You pee it out, right? So in order to pee it out, it has to get to your kidneys, and then you pee it out. So what happens is after birth, it really starts in earnest within the first 24 hours after birth. All that fluid, extra fluid in the blood starts coming back out of your body through urine. In addition, not only that, you've got that extra 1 to 1.5 liters I just talked about in your bloodstream, but also almost all pregnant women have lots of edema. Now that fluid volume in your vessels is not edema. You all understand the difference? Edema is fluid in the soft tissue in the cells in the extracellular space. Pregnant women's hands are swollen. Their feet are swollen. Their nose might be swollen. Their face might be swollen. That is not in the blood vessels. That's in the cells, in the inside and outside the cells, but not in the vessels, in the soft tissues, right? So how does that get out? How do we get rid of that? What does it have to do to get out of the body? Where does it go? From the soft tissue, how does it leave the body? So if you have swelling in your hands and your feet, well, that is third spacing. That is third spacing. All this swelling that you have is third spacing. So how do you get rid of third spacing? It has to seep back from that soft tissue, seep back into your blood vessels. It has to diffuse back into your blood vessels, right? It's the only way for it to get out. It diffuses back into your blood vessels, then your kidneys filter it, then you pee it out. So now you have two different sources of extra fluid you're getting rid of through your vascular system. You have all the extra fluid that you already had in your vessels. Now you have all the swelling that you had diffusing back across into the vessels. Does that make sense? Everybody with me? Okay. So what kind of a workload does that place on your heart? A lot. So pregnant women who just had their babies, I should say, within 24 to 72 hours, they start peeing like crazy. And those of you women who had babies can probably attest to this. Your urinary output will be 300, 400, 500 mLs per hour for several days after birth while you get rid of all that fluid. And then let's say we throw a patient, you had an epidural on top of that, and they gave you an extra 3 liters of IV fluid in your epidural, or because of your epidural tube. Now you got to get rid of that too. So it's a wonder all of us don't end up in congestive heart failure with all that fluid that we have to get rid of. If you have a young, healthy heart like most pregnant women do, your heart can handle it. So what's happening is all this fluid is moving into the vascular space. So your vascular space is getting bigger and fatter, vessels are full. And then it filters through your kidneys and you pee it out. A lot of women will also have night sweats. That's an alternative way of getting rid of fluid. But the vast majority leaves the body through the urine. Okay? So this is a normal occurrence. The problem is if you have a heart problem, what is that going to do to that patient with a heart problem? It's very difficult. If you have a problem with, you don't have good cardiac output, you're going to be in trouble. So it's really critical that you have a really good heart. If you don't, we're going to have to watch you very, very carefully postpartum. Okay. Does that make everybody understand it? That's the normal thing that happens. You've got that. When you have swelling and fluid in your soft tissue, that is third spacing. That's the definition of third spacing. It's out there in that tissue. So in order to get it out of the body, it has to diffuse back into the bloodstream, back into the vascular space, where it can then filter through the kidneys and out of the body. So it takes several days for it to happen, but it does happen with every woman who has a baby. Okay, so all that is why women are at risk after birth if they have any kind of cardiac issue, especially if it affects their cardiac output. Patients who have underlying cardiovascular disorders have increased risk of miscarriage, and usually we attribute that to medications prescribed and anoxic issues. Anytime you have an incident in early pregnancy where there's an incidence of anoxia or hypoxia, we know that that puts a fetus at risk because when you are, when you need blood to vital organs, your blood shunts, your body shunts blood to the vital organs. Your uterus is not a vital organ. You do not need your uterus to survive. So blood doesn't get shunted there in emergency. So if you have any kind of an emergency or a situation where you have a heart issue and your blood gets shunted to your vital organs, it gets shunted away from the uterus. And if that happens in early pregnancy, a lot of times we see miscarriages. For example, I had a patient once years ago. This was not an OB. I was working on a trauma floor. We had this patient who was young, in her 20s, and had a really bad car accident and was pregnant, like 6 or 8 weeks pregnant, not very pregnant at all. She had a baby in the back seat. She turned around to give something to her baby and ran off the road and hit the guardrail. The guardrail literally, this is off topic, but it's an amazing story, came up between her legs and cut into her groin right here, and her, leg was hanging up here at the top of her iliac crest, basically, that close to losing her whole leg. I mean, I can remember Dr. Sibley telling us that he could put his hand inside her vagina and he could feel her iliac crest. It was pretty amazing. So she was in the hospital back in those days. There weren't rehab. She was in the hospital for like 6 months. She was pregnant, and what her OB doctor told us, after all, she had multiple surgeries, and we asked him what to do about the pregnancy, and he said, "Don't do anything. Just let it ride, and the odds are within a few weeks she's going to lose the pregnancy." Not because of the medications you prescribed, although those are problematic, but because at the time of the accident she had, hypoxia, and so therefore she had anoxia to the uterus because all her blood was shunted to her vital organs to save her life. So she had a real lack of blood flow to the uterus, and that probably will cause that pregnancy to be lost. Sure enough, about 3 weeks later, she started having some bleeding. She had a miscarriage. She lost the pregnancy. And just like clockwork, exactly like you predicted. And it was related to anoxia to the fetus as a result of blood shunting away from the uterus to save her life. So what helped save her life, unfortunately, helped, contributed to that miscarriage. However, she may not have survived, without that. So if she didn't survive, obviously the baby wouldn't survive either. So if all the medications prescribed for cardiac problems don't get you, an anoxic issue or hypoxic issue to the mom may cause miscarriages as well. Preterm labor and birth are more prevalent with cardiovascular disease, and there's a lot of reasons for that. It depends on what the disease process is. Intrauterine growth restriction is more common. How well the baby is doing, how much oxygen and nutrients the baby gets, is going to contribute to intrauterine growth restriction. So again, if there's not enough perfusion to the baby, it's going to cause intrauterine growth restriction to that baby. That door is insane.
It's driving me nuts.
We went out there and asked them, it closes on its own. We asked them to put a thing in it and prop it open or close, and they did. So I don't know what happened now. It's annoying. We've asked them twice already today to prop it open or keep it closed. Incidence of congenital anomalies, interestingly enough, is increased with children of mothers with congenital heart disease. So if a mom has a congenital heart defect, babies are at risk as well. It's a very interesting finding. And there's also something called peripartum cardiomyopathy. So if what I just talked about, what I stood back here and talked about, getting rid of all that extra fluid after birth, if that does not happen appropriately, if the mom can't do that, if she can't rid herself of all that fluid, she will get something called peripartum cardiomyopathy. When that happens, the heart muscle hypertrophies, and the walls of the heart get big and fat. And if you know anything about the heart, you know that cardiomyopathy often leads, if it's bad enough, leads to what? Having to have transplant if it's bad enough. So for patients who cannot excrete all that fluid, it will lead to peripartum cardiomyopathy. Sometimes it will reverse itself. Sometimes there are women who may end up having to have a heart transplant. Mitral and aortic valve stenosis is something that would be pre-existing. And stenosis just means what? If someone has stenosis, what does that mean? What is the definition of stenosis? Narrowing. So the atrial and aortic valve are stenosed or narrowed. Mitral valve prolapse is very common, very benign. If you have that and you're pregnant, usually we just give you antibiotics about the time of birth. You get antibiotics when you go to the dentist. That's a benign condition that is a pre-existing condition. Atrial and ventricular septal defects. If you have a septum or an opening that is not closed between the atria and the ventricle, that's problematic because what have you got? You've got mixing of oxygenated and non-oxygenated blood, right? So that can be a problem too if someone has that as a pre-existing condition. Tetralogy of Fallot. This is a cardiac anomaly that is composed of, next slide, 4 different defects. If you have tetralogy of Fallot, it's 4 defects. Pulmonary valve stenosis, right ventricular hypertrophy, ventricular septal defect, and overriding aorta. You don't need to remember all those, and you do not need to memorize that by any means. But I do want you to be aware of the term tetralogy below, and it is a combination of 4 cardiac defects. So this is a congenital anomaly. Who is at risk of developing? So what patient would be at risk of having a baby with tetralogy below? She was exposed to German measles, otherwise known as what? Rubella. Having a baby with Down syndrome is at risk of having tetralogy below. Poor nutrition in pregnancy, maternal age over 40, alcohol use in pregnancy, all are risk factors for the development of tetralogy below in a fetus. Now, if we have a mom who has tetralogy below, usually by the time she has a baby, all those things have long been fixed and fixed. So usually when you have that, you have surgery when you're very young or multiple surgeries. So if you're pregnant and you have had that, we're just dealing with whatever leftover complications there may be from it. So you can have a mom who had that as a baby and is now an adult and pregnant, or we think about a pregnant mom, what are the risk factors for having a baby with tetralogy below? So these really what I just want you to remember are the risk factors. Rubella or German measles, when you all get your NMR, that covers the measles, that's rubella. Anybody who's exposed to rubella and is not immune, any woman, if you're exposed in the first trimester of pregnancy, you're really at risk for a lot. That's one of the congenital defects, but there are others. That's why we test every pregnant woman for immunity to rubella. We're starting to lose our immunity to it, is what we're learning. So if we find a woman is not immune, then after the pregnancy, we will immunize her. And we can't immunize her during pregnancy because it's a live vaccine. But we will immunize her after pregnancy. So don't forget that, the association between rubella and cardiac defects, tetralogy of the lung. Rubella equals German measles. What if your patient has infective endocarditis? How do they get that? Infective endocarditis, they get that from doing what? IV drugs. This is the patient who's using heroin and comes in with endocarditis from drug use.
That can also happen from really poor oral hygiene too, right?
It can, yes, it can. People who don't have any dental care, they've got lots of that's when they say people that have heart problems as a result from bad teeth, that's what they're talking about. People who a lot of really poor dentition, and yes, there's an association with that. Marfan syndrome is a genetic anomaly that comes from connective tissue problem, and that leads to what it leads to is an aortic aneurysm. I don't know if any of you all, Ms. White talked to you all in the first semester about having open heart surgery. I think it's maybe 2010, something like that, she had open heart surgery. She has a form of Marfan syndrome, and her brother had the same surgery. She doesn't have the appearance of anybody with Marfan syndrome, but they do have that congenital part of it that has the congenital anomaly to the aorta. But there's a lot of people that have the Hogue syndrome, and it makes them, they're very tall, they have severe scoliosis. We had a student here who died of, she graduated and later she died of that, having the surgery to correct the aneurysm. But that, if we have a pregnant woman who has that, obviously that's going to impact the pregnancy. Eisenmenger syndrome is just a right to left shunting of the atrial ventricle. So again, you got mixing of blood. Anytime you have mixing of blood between the atrium, the two sides of the heart, we worry about poor oxygenation because you're mixing oxygenated blood with poorly oxygenated blood. It's going to reduce your oxygen levels. For myocardial infarction, I have taken care of a few women who actually had a heart attack, either before, in the past, or a couple of women that had heart attacks after they had the baby. And the reason they had heart attacks after they had the baby is because of all that fluid that they had. And they couldn't get rid of it because their heart just wasn't strong enough. And a couple of them end up having MIs. So that can occur when you're trying to get rid of all that postpartum fluid volume in the body. So, we think of having a baby is no big deal. Oh, no big deal, any young healthy woman can do it. And most of the time that is the case. But let's face it, it's a lot. There's a lot going on in the body. And there are women who every year who end up in Cleveland Clinic and all lots of other places because cardiac problems that develop as a result of trying to not get rid of all that fluid and end up in congestive heart failure or with an MI or something like that. There is a minority, in the country, but It definitely happens. What if a patient's had a heart transplant? And I think we briefly mentioned that last week when we talked about birth control, or a week before last, and I said, what about a woman who's waiting on a heart transplant? What kind of contraceptives do we want? Because we certainly don't want her to get pregnant. But we do see women post-transplants, they ask them to wait at least a year, minimum of a year to wait. But after that, they are successfully completing pregnancies now, and they will allow it. We ask them before they conceive to have their ventricular function assessed to make sure they have good ventricular cardiac function, meaning they have good cardiac output. That is key to pregnancy, having good cardiac output. So based on everything I just told you, does that make sense? How important cardiac output is to successfully completing pregnancy? Most definitely. So we like for them to have a vaginal birth. It's not always possible. So in some cases they might do a C-section. Vaginal births are preferred, but sometimes if the pushing becomes pronounced and that Valsalva maneuver can become problematic for some people, so sometimes they will do C-sections. Most of the time, complications of patients who've had heart transplants are this. There are all kinds of anti-rejection meds for life, right? So if you have to have a heart transplant, you know you got to be on medications for life to prevent a rejection of the heart. So what do we do during that first trimester when organs are forming? How do we handle that? Well, usually what they'll do is they'll take the patient off of those anti-rejection meds just for one trimester. Just for that period of time while the organs are forming, and then put them right back on and hope that they do okay. But because of that, they often have at least one episode of rejection of the heart during pregnancy, and they have to deal with that. But the safest thing to do, if at all possible, is to take them off their anti-rejection meds for the first trimester. So as I said, conception should be postponed for a year. The neonate may exhibit, when the baby's born, the baby may be immunosuppressed. Does that make sense? If the patient's on anti-rejection meds, is she immunosuppressed if she's on anti-rejection meds? She's immunosuppressed. So the baby's going to be immunosuppressed until those meds get out of the baby's body. So we've only taken mom off those meds for the first trimester. So at birth, the baby's still getting those in their system. Breastfeeding is not advised for infants of moms who have transplant because of medications. And again, postpartum remains a critical time for all cardiac patients. You see all the stars I have there. As fluid shifts begin and the body begins its diuresis. The body's diuresis is going to be key here. We've got to watch mom and how well she diureses and gets rid of all that fluid. Okay, so one of the things we watch for our cardiac patients is signs and symptoms of cardiac decompensation. So let me read these symptoms and you all tell me what this sounds like. Dyspnea, moist cough, palpitations, irregular weak pulse greater than 100, generalized edema, crackles at lung bases, tachypnea, cyanosis at nail beds. What does that sound like to you?
Pneumonia.
CHF. CHF. It might sound, pneumonia might be some of those, but CHF is what it really sounds like. So what we're looking at, we're watching for our patients with congestive heart failure. That's cardiac decompensation in a pregnant woman. So if our patient has cardiac issues, those are the symptoms that we're watching for. And they're really just signs and symptoms of CHF. Limit activity, we certainly don't want them to stress themselves. This is not the patient that we want to go out and swim every day or jog a mile or we want to maximize oxygenation and limit stress on them. Remember the risks postpartum when fluid mobilizes back into the intravascular space for diuresis. Watch it very carefully at that time. There's a drug we use in pregnancy for preterm labor, and it's called terbutaline or breathine is the generic name. This drug mimics many signs of cardiac decompensation, so it should not be used in these patients because it will confuse us. They'll have high heart rates and they'll cough, and we may get confused and think they're having cardiac decompensation when really it's a side effect of this medication. So just remember, terbutaline / breathine generic name should not be used in cardiac patients because it mimics a lot of the effects of cardiac decompensation. And then again, the cardiac medications that are needed for our patient, as many as we can, we hold during the first trimester. So our patient during the first trimester, they're really going to be on the most minimal meds that we can possibly keep them on up until they're about at least 12 weeks. At 12 weeks, we can reevaluate and try to put them back on. So it's benefit risk evaluation. Every patient's going to be different. It depends on how severe their case is, what their doc thinks, but it's benefit risk. We want them to be on those meds all the time, but we also don't want them to have a baby with tetralogy of Fallot or other anomalies. So we have to weigh the benefits and the risks. Okay, any questions about that? We're going to move on. That's the cardiac section. So you can see of this whole chapter, the two biggest things definitely are cardiac and then diabetes. So what we're talking about are patients who have those pre-existing conditions. Anemia. Iron deficiency we've talked about. That's the most common type of anemia. We also can have folic acid deficiency anemia, which is, again, low folic acid levels. Sickle cell, for patients who are at risk of sickle cell, African American or Mediterranean individuals. Those patients are at higher risk of preeclampsia, preterm labor, and some other issues. And then thalassemia is a disorder where the hemoglobin is insufficient to fill the red blood cells. So they have hemoglobin, but it doesn't appropriately fill the red blood cells. We treat them like sickle cell anemia. All right, so now let's talk about a little bit about asthma. I think there's like one slide on asthma. All I want you to remember is, as you know, asthma is a chronic inflammatory disorder where the tracheobronchial areas constrict from, usually there's a stimulant, an irritating stimulant that causes it. So our goal is to maintain adequate oxygenation in mom and in baby, and we're trying to prevent any hypoxic episodes in mom. That's the bottom line. Prevent hypoxia is our goal in treating asthma. Relieve the bronchospasm. So we give corticosteroids to the patient to relieve that spasm. If you have a stimulus, something that causes the asthma, brings it on, that's the stimulus. The trachea and bronchial areas constrict, and therefore the patient has trouble breathing, so that can bring on a hypoxic episode. And in pregnancy, 1/3 of the time the patients do better. As pregnant women, their asthma is better. 1/3 of the time they do the same, and 1/3 of the time they do worse. So it's kind of a crapshoot as to how they're going to do. Is their asthma going to be worse 1/3 of the time? Is it going to stay the same 1/3 of the time? And it's going to actually be better 1/3 of the time. Okay, for patients who have gallstones or have appendicitis and have to have surgery during pregnancy, what if something comes up and you can't ignore appendicitis, obviously. I don't care how many weeks your patient is, if she's 6 weeks, 8 weeks, 40 weeks. If she has appendicitis, we got to do something. We don't want a ruptured appendix on our hands. So any patient who needs surgery, no matter how pregnant she may be, will have to have surgery. And that will mean most of the time general anesthesia. And that is okay. They will adjust what they give the patient in surgery. They'll do a different anesthesia than they would if she weren't pregnant. And we will manage them, if it's in the first or second trimester, we just treat them as best we can. If it's in the third trimester, we'll monitor the baby and make sure the baby's doing okay. Post-op, they can have pain it's okay to have pain medications. Babies tolerate pain medications fine on a short-term basis. We want to, get them up. We want to prevent postpartum complications like blood clots and things that are all post-op patients are predisposed to. But it is okay to have surgery if it is necessary. The key is going to be adjusting the medications and anesthesia uses so they know what to use and what not to use. Preventing any complications of immobility. And monitoring the fetus if the fetus is viable, meaning if it's in the late second or third trimester. We'll monitor the fetus very carefully. Okay. Melasma and chloasma, we talked a little bit about, I think, in the previous chapter as far as changes during pregnancy. It's when you have brown spots across your face, or it looks like a butterfly across your face right here. Brown pigment comes from hormones. If the patient's pregnant, we call it melasma. If the patient's not pregnant, they get it, we call it chloasma. If they're not pregnant, it comes from progesterone and not estrogen. If they are pregnant, it comes from estrogen. So that is just something, and there's a picture of it up there. You can't see it very well in that picture. It's the best one I could find. It just usually comes and goes. We don't do anything about it, but you do need to be aware of what it's called. Vascular spiders, look like little red lump spiders in the extremities, increased estrogen levels in the blood. Palmar erythema, again, increased estrogen levels in the blood. And then striae gravidarum are your stretch marks that most people know what they are. I've got a picture here of the palmar erythema. See how red those hands are? That's a picture of that. And then your striae gravidarum or stretch marks. The younger the patient, the worse their stretch marks will be. I've seen some young teenagers, like 14, 15, that literally I felt so sorry for them. The stretch marks were so bad because their skin is not ready to stretch at that extreme. That's minor compared to some that I've seen that are really, really bad. Stretch marks do not go away. They do fade in time, but they do not go away. You can feel where the skin is stretched forever on your lip. But they do not, while they do fade, they do not go away. Neurologic disorders. What if your patient is pregnant and has a form of epilepsy or any other type of seizure disorder? Well, how do we manage that? One of the most common problems that we see is that the patient they want to not take their meds. You know, it's kind of out there that seizure or anti-seizure meds are bad for babies. And so we get patients to be very non-compliant, just stop taking their meds. I'm pregnant, I'm not taking them. And so they must take something, obviously. So we want to make them aware that yes, some drugs are harmful to the fetus, but you've got to take something. Our best choices for childbearing women are Keppra and Lamictal. Keppra is used a bunch. Lamictal is also used. We avoid Depakote, we avoid Valium, we avoid Dilantin. We avoid Depakote, we avoid Valium, we avoid Dilantin. Now let me say about Valium. If your patient's in the third trimester and they're seizing and someone gives them Valium, that's not the end of the world. What we worry about with Valium is that it's a teratogen. So if the patient is 40 weeks, are we worried about teratogenic effects at that point? No, the organs are already formed, so it's probably fine. And usually we give Ativan anyway in this day and age. But if someone does give Valium and the patient's term, that's fine. We certainly don't want to give Valium to somebody that's 8 weeks pregnant because it's a teratogen and they're teratogen. But if they're full term, that's a different story. Lamictal and Keppra are good choices for seizure, anti-seizure medications for childbearing women, as I said. And there's a few of these medications that can deplete folic acid levels, so moms who have seizure disorders should be sure to supplement their diet with folic acid. Multiple sclerosis or MS, which you guys learned about earlier this semester with Dr. Sayre. I'm going to say very little about it. We don't see it in pregnancy very often. It's not often diagnosed at young age. But what we do is we treat the patient with bed rest and steroids to hopefully prevent an exacerbation during pregnancy. That's our goal. Prevent an exacerbation during pregnancy. And then this picture up here is a picture of Bell's palsy. Sometimes for no known reason that we can figure out, a patient will develop Bell's palsy during pregnancy. It doesn't mean they've had a stroke. It doesn't mean anything, oftentimes. We don't really know what causes it. If I was guessing, I would suspicion that some of the extra fluid that causes it, because we know that extra fluid can cause carpal tunnel, which is a displacement of the nerve. So my own personal theory is that extra fluid in the vascular system can cause displacement of the nerve and can cause a Bell's palsy. Typically, it goes away after pregnancy. So will we assess that woman for any neuro problems? Absolutely. We will do a neuro assessment. But usually Bell's palsy is not related to any neurological disorder in pregnancy. It comes and it goes away after pregnancy, usually.
You're saying it's usually not related to neuro?
It's not related to neuro typically in pregnancy. Autoimmune disorders. And I want to lump them all together because oftentimes they work the same. Whether you have lupus, whether you have Crohn's disease, whatever autoimmune disorder you have, what patients usually find is when they're pregnant, they get better, way better, significantly better. So let's think about that. What happens to the immune system in most pregnant women? You ready to know? Is it amped up or is it decreased? It's decreased. For whatever reason, and I don't know the theory behind. There's some theories that because that there are some theories that actually some women actually have a immune response against sperm. There's a theory that there's some people have had multiple miscarriages, and then they have a new partner, and all of a sudden they get pregnant with no problem after multiple miscarriages with a different partner. So there's some theories out there that the immune system sometimes can, turn on even sperm, and so we believe that the immune system in pregnant women is decreased. Pregnant women are immunocompromised just a little bit. Not a lot, but just a little bit. And we believe a lot of it is to help sustain the pregnancy and, the foreign cells that are there. So the immunocompromised state, just a minor immunocompromised state of a woman. What impact do if we think about autoimmune disease, what is happening in autoimmune disease? What's your body doing? Your body's attacking itself because the immune system goes in overdrive. So if you've got an autoimmune disorder, your immune system's in overdrive. So if in a pregnant woman we know that autoimmune system gets tamped down and you're a little bit immunocompromised, does it make sense that your autoimmune disease will get better? Because your body's not doing that. You're compromised a little bit, and so your body's not fighting itself, and so any immune system disorder that you had, autoimmune disorders, I meant to say, usually gets better. So the patient who has lupus, the patient who has Crohn's, they say, my gosh, I've never felt this good in years. I feel great. Their disorders get better because the body becomes immunocompromised during pregnancy. So it minimizes that body's fight against itself. It stops it. Unfortunately, what happens is after the baby's born, it comes roaring back. So usually within 6 weeks, whatever their condition was will return to the same level it was, if not an exacerbation. Some women will even have an exacerbation after the first 6 weeks of postpartum. So I want to make sure y'all understand that. So if you have an autoimmune disease, your body's fighting itself. For some reason, your body's on overdrive, your immune system's on overdrive, and it's attacking itself. If we know in pregnancy, the body's immune system kind of goes on a little vacation, and it goes kind of into a dormant state, so you're a little bit immunocompromised, it's going to cause any autoimmune disorders that you have to get better, because your body's no longer fighting itself. Right? Everybody with me? Okay, good. So again, within the first 6 weeks after the end of pregnancy, it will return, unfortunately. Okay, let's talk about HIV and AIDS. You might be able to explain that. So, obviously, if the patient's HIV/AIDS, whichever the case may be, is not under control, we don't want them to get pregnant. So we would advise them, as far as preconception counseling, not to become pregnant until their condition is well under control. Surely, number one. Treat any opportunistic infections that we need to treat. Pregnancy does not accelerate the condition. Again, this is not necessarily an autoimmune disease, but it is an immune system disease. So if our immune system is kind of tamped down, it makes this disease do nothing different. So HIV does not get worse during pregnancy, it does not get better, it just stays the same typically. Now, if a woman, and most patients with HIV are on the antiretroviral drugs, if they're on those, we most definitely want them to stay on them during pregnancy, with the possible exception of the first trimester. So should be starting to see here that almost any condition, if we can take patients off meds during the first trimester, we will, during the time that the baby's organs are forming. So we would like to take them off that antiretroviral therapy during the first trimester if we possibly can, and put them back on it as soon as the first trimester is over. What that antiretroviral therapy does, it's not really for mom, it's for baby. It's to prevent mom from transmitting the virus to her fetus. So that antiretroviral therapy is to prevent mom from giving the virus to the fetus. And the transmission, we believe that in the United States, only 1 to 200 a year are infected in utero if the mom's taking antiretroviral therapy. So we're pretty successful at preventing mother-to-child transmission. Also, if a patient with HIV gets pregnant, we want to test them for all other STIs and hepatitis. Why are we going to do that? Why are we going to test them for all STIs and hepatitis?
They already have an immunity issue that's really tanked,
That's exactly right.
and so they can be open to God knows what.
Yes. Do they usually going to have Hep B, Hep C, some STI? They've got an immune system that's not functioning properly. So if they were exposed to HIV, they're likely been exposed to other things, and they're much more likely to get them because their immune system is on the run. They don't have a good immune system. So we want to make sure that they don't have STIs and hepatitis that we know, but we make sure that we at least know about it. I can't tell you how many moms I've seen. We see a lot more with Hep C than we do HIV, to be honest with you. Many more. I see Hep C moms come in all the time. HIV a little less frequently, but lots and lots of Hep C. Okay, nursing management. So if a mom is HIV positive, it's a C-section. No labor. C-section. The reason is, we've worked hard to prevent transmission to the baby all during the pregnancy using the antiretroviral drugs. We don't want to transmit that to the baby now. If we break the mom's water, that ends the protection. That bag of water is protecting the baby from the mom. So if we break her water and she goes into labor and the baby comes through the vagina, the baby's risk factors for getting HIV are greatly increased. So we do a C-section. Now, when the baby's born, is the baby then exposed if the baby's born by C-section, is it exposed to blood and fluids? Yes, we can't help that. But what we can do is take the baby out quickly, and we can dry the baby and give them a bath very quickly. So for these babies, this is the baby that doesn't get to stay in the OR at all. As soon as the baby's resuscitated, if resuscitation is needed, it goes to the nursery for a bath, and we clean that baby very vigorously. And this is the case for Hep C or HIV. Now, a lot of times now they're doing something called, in the nursery called delayed bathing, where they wait and don't bathe the baby for the first 8-10 hours, and there's a whole theory behind it. This is the exception to that rule. HIV moms, Hep C moms go directly to the nursery for a bath very quickly. And again, we're trying to prevent transmission. All the baby needs is a little, opening in its skin somewhere and get that, some blood in that and risk transmission. No breastfeeding, of course. Again, we don't want mom to transmit that to baby via breast milk, so no breastfeeding. I have seen babies actually, this doesn't happen very often, but in an emergency situation, I've seen babies be cut by the scalpel. I saw a baby get cut like this one, all the way across from its cheek to its ear in an emergency C-section. So, you think of something like that, heaven forbid that would happen in an HIV positive patient, that would be terrible. But that would certainly increase the risk. So any kind of any kind can put the baby at significant risk. So we want to get them cleaned and bathed very quickly. Again, take mom off antiretroviral drugs during the first trimester. Again, that's a doctor choice. They have to look at the patient's condition, look at their viral load, make a decision, risk benefit. It's a risk benefit decision. So that's going to be between the doctor and the patient. But that would be best for baby in terms of teratogens and those medications. Certainly. Oh. And then our last thing, I think the last thing in this chapter is substance abuse, and it's actually 11 o'clock. So we'll stop right here. We'll finish this. And chapter 12 is very long, too. It'll probably take us most of the day on Wednesday to get through chapter 12. So we'll go through this chapter. We'll finish this in chapter